Well, welcome to day one of Consumer Action's Health is Wealth convening. We will begin soon, but first, a few housekeeping items. First, from the control panel to the right of your screen, you may use the Q&A section to submit questions. Time permitting, we will field some questions at the end of the panel. In the control panel, you will also find today's program under Handouts. Go to Webinar offers multiple view options. To select your preferred view mode, from the top menu bar, you must select to view everyone or the person speaking. Finally, today's event is being recorded and will be made available for future viewing. Now I'd like to introduce today's keynote speaker and MC for the convening, consumer reporter Herb Weisbaum. Herb is one of America's top consumer experts. He's been protecting consumers for nearly 40 years. Herb is a consumer reporter at KOMO Radio in Seattle and a contributing editor at checkbook.org. Over the years, he's been known to many as Consumer Man. During his distinguished career, Herb has covered the consumer beat for NBC News Digital, NBC's Today Show, and CBS News. He's exposed everything from quack medications to bogus investments. A 5-time Emmy Award winner, Herb's dedication to protecting consumers has been honored by the Consumer Federation of America, United Press International, and the Society of Professional Journalists. He also received Consumer Action's Consumer Excellence Award in 2008. Today, Herb will kick off Consumer Action's Health is Wealth convening with a brief keynote speech, then moderate the panel of experts who will discuss the nexus between consumers' physical and financial health and offer innovative and practical solutions to dealing with surprise medical billing, medical debt, and healthcare and coverage during and after a pandemic.
Good morning or good afternoon, depending on where you are. I'm coming to you from the great Northwest and Bellevue, Washington, where we're having a beautiful sunny day outside. For those of you who aren't familiar with the Northwest, we're just outside of Seattle. So Seattle is a 15-minute ride. The anarchist city is a 15-minute ride to the west. Canada is a 2-minute ride to the north. That's they don't want us there because we have COVID. And then New York City and Boston and Washington, D.C., you guys are all about 3 million light years to the east of us. So it gives you an idea of where I'm coming to you from today. I want to start off by talking about the elephant in the room, of course, which is the COVID pandemic. I just checked. It has now claimed the lives of more than 205,000 Americans. I get chills just saying that unbelievable number, 205,000 Americans. Have you ever wondered how many of these mothers and fathers and sisters and brothers and grandmothers and grandfathers and husbands and wives and kids were Republicans and how many of them were Democrats? Of course not, because the novel coronavirus is an equal opportunity killer. It doesn't know and it doesn't care what your political affiliation is. It doesn't respond with but it does respond with a vengeance when you don't take it seriously and respond accordingly. And the United States, sadly, has proven that big time. When it comes to the COVID deaths, we are number one. We are well ahead of Brazil, India, Mexico, and the United Kingdom. Not a contest we would like to win. For years, I've questioned why healthcare is a partisan issue in this country. It just doesn't make any sense to me. Republicans get cancer. Conservatives die from heart disease. Kids in both Republican and Democrat families get leukemia. As long as I live, I will never understand why some people view healthcare as a privilege and not a right. Healthcare should not be a partisan issue. One person's political opponents are not the enemy. Disease and death are the enemies, all of our enemies. And yet when it comes to keeping the people of this country safe and healthy, the prime responsibility of any elected official, especially someone elected to Congress or the White House, Republicans and Democrats could not be farther apart. The Great Divide, which translates into a status quo mostly, means failing to deal with the country's failing healthcare system. And it is causing needless pain and suffering for millions of people. And it's just not right. The administration constantly tells us that America has the best healthcare system in the world. And for some people, in some places, in certain socioeconomic and racial groups, that is absolutely true. But equal access to quality healthcare is an illusion. Healthcare, unfortunately, is not colorblind in this country. And like so many other things in our society right now, those who are well off get treated better. Let's not forget, some people in some parts of this great land of ours don't have high-speed internet access. Those in inner cities, or some of them down on the farm, they cannot reap the benefits of telemedicine, which we will talk about in great detail tomorrow. About half of Native American households and more than 4 in 10 Latino and Black households have serious internet connection problems. And some of them don't have any high-speed internet access at home at all. This is according to a new survey by the Robert Wood Johnson Foundation. 4 in 10 Latino and Black households, serious internet connection problems. The survey also found, not surprisingly, that the health and economic ramifications of COVID-19 are continuing to hit Black, Latino, and Native American families the hardest in this country right now. Now, I'm sure I'm not telling you anything you don't already know, but I think we need to be honest about the current situation and condition of healthcare in this country today. Fact, the healthcare system in this country is broken and needs to be fixed. We have some amazing researchers, some wonderful doctors, some fabulous medical institutions, but as a system, it is broken. And we must come away from this conference vowing to continue the ongoing fight to make things better for everyone. The COVID pandemic has stretched resources to the limit, as I'm sure you are well aware, and then some. In some places, it has almost broken the system. As a result, it has focused attention on just how fragile healthcare is in this country right now. But even in normal times, there are serious problems. Too many Americans cannot afford their meds. Too many have to wait weeks or months to see their doctor. Too many face serious or life-threatening mental and financial consequences when they're blindsided with unbelievable medical bills, in many cases from out-of-network doctors. I want you to take a look at what I'm talking about. Here's a story from my TV station here in Seattle, KOMO TV, that recently talked about the problem of these medical billing issues.
When Bill Linden's wife, Kate, was rushed into an emergency C-section, he was only thinking about one thing.
It's a life or death situation. Baby has to come out now. Period, end of story.
He wasn't thinking about the anesthesiologist that was brought in or whether insurance would cover it.
I was not really thinking about paperwork at that point in time.
But paperwork would soon be all he'd think about. Bill started arriving saying he owed roughly $2,500. Many phone calls later, he discovered it came down to a network classification. The anesthesiologist was considered out of network, even though the hospital was in network. Bill said it took 14 months to determine he and his wife did not owe the money.
It was a lot. It was a lot.
Consumer Reports' Penelope Wong says it's hardly uncommon.
There's a very good chance that your billing problem will drag on for weeks, months, or even years.
A recent Consumer Reports survey found 2 out of 3 people with a major health expense in the past 2 years had an issue with their bill. More than a third said they paid bills they weren't even sure they owed.
They felt it was too much trouble or too much effort to fight.
What can you do to fight back? Bill ultimately worked with a nonprofit patient advocate that laid out the steps he should take.
This is the documentation you need to get. This is who you chase down. Send things certified mail.
You can also hire a medical billing advocate for a fee.
Okay, it's just a little example of what we're talking about here. And a Consumer Reports investigation into medical bills, which just got released today, found that medical debt is now the top reason why people file for bankruptcy in this country, the #1 reason. And to make matters worse, worrying about medical debt is actually making people sick. They're putting off going to the doctor. They're cutting back on their meds. In some cases, it is causing depression. The Consumer Reports survey out today is based on a survey taken in June. They spoke to more than 1,200 adults who had a medical billing problem that had to be paid out of pocket and were asked to deal with it. And here's what they said the result was. 41% said they put off a doctor's visit because of this unexpected cost. 32% treated themselves at home rather than go to the doctor. 20% decided not to get a recommended test or procedure because they could not afford it. And 15% did not fill a prescription because of the cost. These are all things that are not good. These are all things that could lead to more serious medical problems and more cost for the entire system because problems aren't dealt with when they're small. People wait until they're totally out of hand and have to rush themselves to the emergency room. Many people can't afford their meds, so what they're doing is they're taking a half a dose or skipping every other day. I've spoken to people who do that. In both cases, they're not getting therapeutic doses of their medication, so it's not really doing them any good. So we find ourselves in America, the richest country on the planet Earth, in a situation that's not only tragic, but it is inexcusable and, in my opinion, unacceptable. And speaking of skyrocketing drug prices, just listen to this. The cost of the top 17 best-selling brand name drugs in the U.S., some household names that you see advertised on TV all the time, brand name drugs such as Lipitor and Lyrica, Advair, and Chantix, has more than doubled since 2012. That's according to a survey conducted last year, published in the Journal of the American Medical Association. Why is this happening? Why are drug prices skyrocketing? Well, the drug companies said they need these profits in order to pay for the billions of dollars that they spend on researching these drugs and to invest in more research to find more life-saving drugs. Critics on both sides of the aisle say that the pharmaceutical industry is greedy. Back in March, on the floor of the U.S. Senate, Iowa Senator Charles Grassley, a Republican, said this, and I'm going to quote the senator. "Let's be clear. These price hikes are not because the medicines got any better or there was a significant increase in research and development. No, this was because pharmaceutical companies can get away with it." End of quote. Senator Charles Grassley. Under the current administration, more than 2 million Americans lost their health care coverage. 2 million of our fellow citizens. According to the U.S. Census Bureau, those who lack health insurance grew from 8.6% in 2016 to 9.2% last year. And remember, the economy was soaring during that time period and unemployment was low, and many people get their health care from their employer. This follows 6 straight years of seeing more Americans with health care coverage because of the Affordable Care Act passed in 2010 by Congressman President Obama. Obamacare, something that Republicans have been trying to gut and kill since President Trump became president, is working. It's actually working. And as the election draws ever closer, the Senate prepares for its rush confirmation of a new Supreme Court justice. More than 20 million Americans now have to worry about losing affordable health care coverage that they now have under Obamacare. 20 million Americans or more. If the court strikes down Obamacare, these hardworking Americans could see their out-of-medical costs go up dramatically, or they could be denied coverage altogether because they have a pre-existing condition. And insurance companies would once again be able to charge men and women different premiums for the same coverage, something that Obamacare outlawed. So on that happy note, let us begin today's discussion, talk more about the problem and hopefully a few solutions. We're going to talk with several experts about the impact of surprise medical bills that can suddenly and unexpectedly destroy your personal financial health. We'll discuss the laws that protect people and the loopholes that you need to be aware of. We'll discuss the devastating problem of medical debt, where a growing number of hospitals across the country have unleashed debt collectors to hound their patients for unpaid medical bills. And we'll talk about some innovative ways to access health care and coverage. So let me introduce our fine panel members who are joining us online right now. First of all, we have Jane Sheehan, Director of Federal Relations at Families USA, a national leader on the healthcare issues representing healthcare consumers. Jane helps implement the organization's work on advancing healthcare coverage for all. She leads Families USA's federal campaign to protect consumers from surprise medical bills. Welcome, Jane. Jenifer Bosco, attorney with the National Consumer Law Center, a great organization, a national nonprofit specializing in legal issues on behalf of low-income consumers. Jenifer advocates to protect consumers from the harmful impacts of medical debt. She also co-wrote the NCLC's Medical Debt Protection Act and is a contributing author to the NCLC's Collection Actions Treatise. And former Congresswoman Allyson Schwartz, president and CEO of the Better Medicare Alliance, the leading research and advocacy organization supporting Medicare Advantage plans. Medicare Advantage is an alternative to traditional Medicare coverage offered through private companies that some of us have. A longtime public servant who served as a member of the U.S. House of Representatives from Pennsylvania, my home state, for 10 years, from my home county, Montgomery County, is a nationally recognized leader on healthcare issues. So thank you for all calling in today. I think we'll get the former Congresswoman on the line once we get an aide to push the right button for her. But welcome to Jenifer and welcome to, there she is. Hello, Congresswoman. Nice to see you. And hello to the both of you. So Jane, I want to start with you because you went to the great trouble of getting special glasses just for this conference. I want everybody to know. My first question to you is, explain to everybody the problem that is taking place with this balanced billing. I mean, you know, when I had an emergency and I had to get rushed to the hospital, I didn't exactly ask the ambulance, where are you taking me? And, you know, if you're unconscious, you know, you don't know if your anesthesiologist is going to be a network. We always tell people, be prepared, be smart. But for some of these things, you can't be prepared, such as the billing with medical. So talk about it if you could.
Yeah, absolutely. So, and thank you for having me. And I believe that Jenifer actually got the special glasses.
But, I'm sorry, Jenifer a minute.
So well done. Yeah, so you know, surprise medical bills, they've been in the news more in the past few years, but this is a problem that's been going on for a while. You know, when you think about out-of-pocket costs in healthcare and what patients and their families pay, you know, oftentimes you have a copay when you go to the doctor, or you have to pay your deductible. especially in those high deductible health plans. It's kind of an unavoidable part of the system, but surprise medical bills are usually more kind of severe, and they're different because, you know, you are insured, you do your research. If you have, you know, planned care, you go to a facility, you go to a doctor who's in your insurance network because you don't want to pay those out-of-network costs. But especially in emergency situations, as you said, where, you know, you can't choose the ambulance that's going to get you. You can't choose the air ambulance in really severe situations. And if you get to the ER, you know, you're not really thinking about, is my doctor going to be in network? If I need surgery, is my anesthesiologist in network? You're just thinking about getting the best care for yourself and your family members. So that's usually when these bills hit. I think about 1 in 5 US adults received a surprise medical bill in the last 2 years. You know, the surprise, of course, comes in the form of that bill that you get. That is the difference between what the insurer is going to pay for out-of-network care and what the doctor or facility is charging. And a lot of times families are not prepared for that financial hardship. I think, you know, the bills can usually, I think the average is around $600, and for many families, that's even more than they can pay out of pocket. But then some can reach thousands of dollars, the tens of thousands of dollars. And, you know, oftentimes these bills are more than what, you know, what the cost of service would be, you know, if Medicare was paying, if your insurer was paying. So that's like kind of a little bit of background about, you know, where these bills come from and what they are. And I would just say, you know, as you said in your intro, we're living now in the midst of this pandemic. And unfortunately, at this time, these bills are becoming more common because, you know, when families are experiencing a health emergency now, or they're seeking routine care, you're being pushed to out-of-network physicians, and hospitals are employing more contract physicians, and, you know, facilities are of course overwhelmed by COVID-19. Plus the economic uncertainty that everyone's facing now, families are less and less likely to be able to handle these bills.
Great. And Jenifer, when this does happen, when you get socked with a big bill, and lovely glasses, by the way, you know, you think, well, it's a hospital. You know, it's not like a credit card company or a auto company. You know, they're going to cut me some slack, but they can be pretty aggressive in trying to collect the money you owe.
Absolutely. They can, and I mean, there isn't a lot of data about this necessarily, but we advocates have the sense that there seems to be an increase in aggressive collection actions taken by some healthcare providers. You know, and that can include hospitals, that can sometimes include the private companies that run the hospital emergency room that the consumer might not even realize that is the entity that's going to bill them. So we absolutely, you know, hear a lot of stories about people having their wages garnished for medical debt, being sued for medical debt, in some cases having civil arrest warrants issued if they don't show up in court, either for an initial proceeding or later on. And so, you know, there are a number of rights that consumers do have, though, and people aren't even necessarily aware of all of their options. I think, you know, initially, before a debt goes into collection, that there are some options for consumers to get assistance paying the bill. Hospitals that are nonprofit hospitals are required to have a financial assistance policy that low-income patients can sometimes, you know, qualify for free care or for charity care from a hospital. Some states have their own laws as well that might apply to for-profit hospitals. There might be insurance options that people aren't aware of. There could be errors on bills. We've certainly seen, you know, there have been lots of studies out there about the rate of errors on medical bills. So it's, you know, important for consumers to get an itemized bill and to check and see if it's really accurate or not. You know, once a debt is in collections, I think medical debt, you know, it's scary, and I think it's something where people feel, you know, understandably very vulnerable about it because, you know, you've gone to a doctor or a hospital for healthcare, you've kind of put your trust in them to help you and to help you get better. And then, you know, there's this really harmful consequence for some people where the medical debt comes back to bite them. And so I think taking a step back and figuring out, you know, if you have medical debt as well as other debts, what is really the crucial debt to pay first? And that you might be tempted to pay medical debt ahead of other debts, but really, you know, there are other debts that have more immediate legal consequences, like you've got to pay your rent, you've got to pay your utility bills, you've got to keep up with your mortgage and child support obligations. And so I think, you know, it's important for consumers to try to take a step back and figure out, you know, what are my rights? how can I challenge this, and how should I be looking at kind of the whole financial picture?
Congresswoman, we're going to talk to you in a minute about some of the things your organization is doing, but since you were in the legislative process, my state, Washington State, pretty progressive insurance commissioner, we got rid of this practice called balance billing, where you have to worry about which anesthesiologist you're seeing or whatever. And Mike Kreidler, when he spoke about it, was pretty clear. He said, you know, when you go in for an emergency surgery, it's not your problem that the doctor that, you know, that you didn't ask for, the anesthesiologist you didn't ask for is out of network. And he basically said, you pay your bill to the consumer, and you guys, the hospital and the doc, you guys work it out. The insurance company, leave the consumer out of it. They did their part. So we've gotten rid of it in our state. Is this a state solution? Is it going to have to be a state solution, or is it something that Congress could deal with and should deal with?
Well, they've been trying to deal with it. So this is not an issue that my organization advocates on specifically, but I do have to say that we're well aware of that issue being out there, and Congress is working on it. The issue is that they have different ideas about how to solve this. And you're exactly right that the issue is everyone sort of agrees that consumers should not have to pay bills that they have no ability to have any impact on how that surprise billing. I myself have asked a doctor once just before it was a screening procedure, but they were putting me under, and I said to the anesthesiologist, by the way, are you on contract, and am I going to get a surprise bill afterwards? Here I am in a hospital gown. I mean, it was a ridiculous thing to do, and probably a little bit obnoxious, but he had no idea what I was talking about. And I thought, how crazy is him that is. You know, when I asked beforehand and they couldn't answer it then, but I thought, oh, I'll ask him right now because I got to make him aware of this. And I hope it helped him go back and make him aware of it as well. But the fact is that consumers should be held harmless in this situation, and the insurers and the government payers and all should really figure out who pays. And it's also about how much gets paid. And obviously, that's a concern. Providers want to get paid what they want to get paid, and not Medicare rates or even above that, or even insurance rates that are negotiated. So it is sometimes when a really big bill comes your way. So I think what you heard is correct, is you should encourage your member of Congress to figure it out and work it out, and we keep being hopeful that it'll get resolved, because it is one of those things that has gotten worse, particularly as economic times really hard, and you know, the difficulty of getting healthcare right now in the middle of COVID is a reality as well. So it's on the agenda. It's just not done yet.
Is it fair to assume that if the anesthesiologist had said, you know, I'm not a network, you would not have pulled out the IV drip and gotten off the table? Is that,
well, that of course was the ridiculous thing about it. But I was like, look, I guess I'm going in anyway, but I want to partly am doing this to make you aware of the situation. So I'm doing my part, even though I'm not in Congress anymore.
I saw Jenifer and Jane nodding their heads. So at this point in time, in the current political situation, it seems like if there's going to be any help for consumers, it's at the state level?
Well, you know, it helps, but I do think that my guess is, I was going to say, I was just going to say, my own sense is some of these things ought to be, and look, it's why I worked in the state Senate, did a lot of work on healthcare, you know, as a state senator for 14 years and then 10 years in Congress. And you know, I think there's great innovation and flexibility for states. That should continue. There are additional benefits that sometimes get added to Medicaid, and there's the health exchanges that are often run by the states that are really working well. So I think states have an enormously important role in healthcare, but there's some rules that ought to be federal rules, and there's some standards that will be set at the federal level. I think this is one that would be great not to go state by state and to have it resolved.
Jane or Jenifer?
Did you answer that?
I think I totally agree that a lot of states have made good progress here. I think about 15 have pretty comprehensive protections. About another 15 or so have some protections, and then the remainder don't have any protections against these bills. But I would say, while I definitely encourage folks who work on the state level to continue to push their states to get these through, because you can't always rely on Congress. They are trying. They've been, working deeply on this for almost 2 years now. Most of the committees of jurisdiction have all put out bills and advanced them through the committee process. There's, of course, as the Congressman alluded to, some disagreements on how you resolve that payment mechanism, like how does the provider actually get paid? But the bottom line is Congress needs to address this. There are loopholes in what states can protect from. Employer-sponsored insurance, for example, which a lot of Americans, as we know, get their insurance that way. That has to be regulated on the federal level. So we need those federal protections. Plus air ambulance, I believe, just because of FAA, that has to be resolved on the federal level too. So I think I would encourage the states to keep going, but in the meantime, Congress is so close, yet a little far, and we would just urge them to keep going on this.
Jenifer, I know a lot of hospitals, medical institutions, especially nonprofit ones, have programs set up to help people pay off bills. I think, and they're proud of this, but I think the problem is, and from personal experience, they don't always volunteer that it's available, that there's help, there's an option. So I think it's pretty important to share with our audience that it's one of those situations where you have to ask about if you get clobbered with a big bill, right?
Oh, absolutely. I think, some hospitals do a great job publicizing their financial assistance policies and charity care policies, and others don't necessarily. And, you might even have to go to more than one person to get the correct information. Under the federal law, under regulations that are part of the Affordable Care Act, actually, the financial assistance rules that apply to nonprofit hospitals also have a bunch of requirements about the kind of publicity that you need to do about your financial assistance policy. So a lot of that information is available online if somebody had the opportunity to do research first. Of course, that kind of ties into another problem, that you don't really shop for healthcare the way that you shop for a new pair of shoes or something. You sometimes don't really have a choice where you're getting your healthcare.
Congresswoman, let's talk about something that you're very active with, the Medicare Advantage programs. A lot of people may not, let's just start from the assumption, a lot of people may not know what these are. There's Medicare and then there's Medicare Advantage. Explain a little bit about that and how that works and why people who are Medicare age may want to consider that.
Well, thank you for the opportunity. I know we're talking about some of the problems here. So I think I should start with why it matters. And I think Herb, you laid this out as you talk about the healthcare system being broken, and there are problems. There's also lots to be proud of in our healthcare system. But in some ways, the healthcare system is the way the financing encourages it to be, and that's the problem. So I'm talking about Medicare now, but it also is the way a lot of commercial insurance works. Less so in these days, but Medicare as well, is that the way healthcare gets paid for in this country is by and large based on fees for services provided. That sounds perfectly reasonable, except what it means is that you really don't have the kind of continuity of care. Is that if you go for a certain episode of care, you might get really good care. But most of us, and all of us worry about that acute situation, but the biggest costs in healthcare, particularly for people over 65, are chronic conditions, which means it isn't just an episode of care. It's care that's pretty continuous. It's chronic. It's going to go on for a long time. You hope to slow the disease progression, but it's not about a single episode of care. So in Medicare, it goes on, it's been around for a while, but it's been growing rapidly in the last 10 years in particular, and is that there's a way, two ways to get your Medicare coverage. You can either go with the traditional fee-for-service system, or you can go with a managed care option, which means that these providers are getting paid a certain amount per member, per month, per enrollee, per month for you to take care of you. And so it means that they don't have to do more things than you need. They don't have to make you go to the most expensive place possible. They actually reach out to you. I think what's really special about it is a lot of focus on primary care, and having a primary care practitioner, might be a doctor, might be a nurse practitioner, to be able to have a care team often. That isn't just a clinician, but an important part of it, but might include a social worker or a care manager, or in some cases we know that there've been a navigator, a community worker who can go out into the district. And the idea is to keep people healthier and to help them manage their chronic conditions and to help them prevent those chronic conditions from getting worse. And it turns out it's working. It's called Medicare Advantage. It's about 40% of beneficiaries in Medicare have chosen Medicare Advantage. That's grown quite rapidly year over year, particularly in the last 5 years. And we've seen some of this also, the incentives and the way the payment works is you pay more if you provide high quality care. You do better if there are better outcomes for your patients. That's pretty amazing. And so instead of that changes the incentives all around. So we see those 40%, it's almost 25 million seniors over 65 and people with disabilities. There are also a lot of choices, so you can pick the healthcare plan that fits your needs. and has kind of benefits. Turns out if you save money by people not going to the hospital principally as a reason, or slowing disease progression, is that you can reuse that money for extra benefits. So they're not paid extra, they're paying the same pretty much from fee for service within, and that's what they're supposed to be doing, but that you can use those to provide extra benefits. And so people find that it's simpler, there are more benefits. Usually it's vision, dental, hearing. Almost every plan has one. Half of plans have all three, plus wellness programs. I mean, it's a joke about, well, exercise programs, that must just be for healthy people. No, it turns out that if you can get seniors with cardiac disease or with diabetes to walk or to exercise somehow, that actually reduces can slow their disease progression and be really powerful. So maybe we'll talk more about it if we have a chance. And now additional flexibility is being offered. It is recent rules from the government allowing benefits to be targeted to people with chronic illnesses, so that things like meal delivery or care in the home or respite for caregivers or adult day even is being added now, including even things like therapeutic massage is now being covered. None of this is covered by traditional Medicare, but because of the savings, beneficiaries get more benefits. So it's saving money for beneficiaries, it's lower premiums than you would pay. You don't have to buy a Medigap policy if you're in fee-for-service. Many people in fee-for-service do, because there are big gaps in coverage, particularly physician services. Savings are about $1,600 per beneficiary at this point. So we're seeing more plans, more choices, more beneficiaries choosing those plans, and very high satisfaction. And I'll make one final point. You talked about how divisive healthcare policy can be in this country. We just talked about it. Turns out that we have support from both Republicans and Democrats. Maybe different reasons, but the fact is that they appreciate the public-private partnership, the transformation in healthcare delivery, and obviously the high satisfaction from their constituents. So we think it's helping to transform healthcare in America, and we're glad to see that. So it's good for people to know about it. If you're over 65, you probably know about it, or, well, turns out a lot of people don't, but check it out. And Herb, I know you have your own personal experience with Medicare Advantage, but also as knowledgeable people about healthcare and people who care about the consumer, you may be asked for help or advice, and just help people just understand what it does and whether it's the right option for themselves.
Although I got to tell you, if I get one more email for silver sneakers, I'm going to throw my white sneakers at my computer. I'll tell you that right now. But
apparently it's quite fun.
I go to the gym. Well, not now, I don't, but I do it at home. But anyway, I think there's a point that I don't want people to miss, which is that where traditional Medicare does not cover, we always hear doesn't cover hearing and vision and that sort of thing. Medicare Advantage, it may be a little difficult, it may be a little not as easy as everything else. Like you have to put in a form to get my plan. You have to put in a form to get the doctor money back. There's a limit. I get like $250 back or whatever. The hearing, whatever, you submit a bill, but I got paid right away, and it wasn't all that complicated. It was better than not getting paid at all. I mean, anything reimbursed. So there are all those additions that are being added to Medicare Advantage plans. To our two consumer advocates, and I don't know, but I always ask, so what's the downside? Is there any drawback? Is there anything people need to consider before they go the Medicare Advantage route, Jenifer or Jane?
I would say I don't know nearly as much as the Congresswoman about these plans. I mean, she's clearly a great expert in this area. I think, just for any, I would just advise consumers to be really, careful and get as much information as possible when they're choosing a plan to figure out, how it fits with their own personal healthcare needs and their anticipated healthcare needs.
Jane, anything you want to add?
No, I think I agree with Jenifer. The Congresswoman's definitely the expert here, and consumers should always just do research when they can and decide what's best for them and their families. So.
It's coming up. We got to choose again before the end of the year, and just because you have a plan you like does not mean it's going to be the same plan next year. So you really got to do your research and make sure that your drugs haven't changed, your medical facilities haven't changed, and that sort of thing. It's a pain to do it every year, but you got to check.
I will say this, and is that I think all of you make a good point, and actually it'd be a Better Medicare Alliance. We feel very strongly about consumers, beneficiaries, actually making an active choice. Right now, if you don't make a choice, you default into fee-for-service. That may not be best for you, but if it's the right choice for you, then by all means check it out. And we have a report coming out, I'll give you a little heads up in the next few days, just about how we could ease the enrollment process for beneficiaries. I think this is an issue, and actually should say Consumer Action is one of our ally organizations. We have almost 150 ally organizations, and Consumer Action is part of it. And they were part of this report we're doing, which really is how can you make what is a complicated process simpler for people. We've been working to get CMS to translate more of their documents in more languages, to make it more easily accessible, to make sure that there's standards out there for, well, there are for agents and brokers, but there are also for there should be also for volunteer counselors, and that we even, well, I won't steal our own thunder. We have some other bigger ideas too, but it is really all about getting the consumer to make the best choice for themselves and to understand their options.
Jenifer, people are always concerned about how things will impact their credit score or their credit files. What kind of damage, I know some things have changed in how medical debt is reported, so bring us up to speed on where we stand and how this could impact somebody down the road for a long, long time.
Well, it's good that you brought up that issue. Over half of the items on credit reports in this country right now are for medical debt, so it is a huge issue. There have been some recent changes that have helped consumers somewhat, I think, and one of them was in 2017. There was a settlement agreement between most of the states' attorneys general, and the 3 major credit reporting bureaus, and that created a rule where medical debt can't be reported to a credit reporting agency for 180 days after your first bill. So that gives consumers more time to find out if the bill is accurate, to make sure to work out payment and everything, to appeal anything that might be wrong. So that's absolutely a protection. There's also a piece of federal law that extends that to 1 year for certain like veterans and military healthcare expenses. So those folks get some extra protection. There are also some updated credit scoring models that weigh medical debt a little bit like lower, like don't give it as much power, I guess, in the credit scoring model. But it really depends on the lender and which credit scoring model they are choosing, but the newer ones weight medical debt a little bit differently. Oh, and I should also say that as part of that settlement, medical debt that ultimately is found to be like the insurance company's responsibility or is paid, that has to be indicated on the credit report, where that wasn't necessarily the case before.
You are author of the, let me sure I get it right, the Medical Debt Protection Act. What kind of things could legislation possibly do? What are you hoping this act would do if it's passed by Congress?
Oh, well, that would be fantastic. It's actually what we did at NCLC was we looked at what are some of the best protections out there among the different states. So California has some really great consumer protections around like financial assistance, and for instance, Massachusetts has an additional credit reporting protection that if you're in the middle of a dispute with your health insurance company, that something can't be reported or sent to collections during that dispute. So we kind of looked around and kind of came up with 2 sets of recommendations. The first is about how to strengthen charity care or financial assistance policies, and those apply at the state level. So it's sort of for states that don't have charity care laws or have laws that could be stronger. It's our recommendations of the kind of guidelines to apply, how much care to give to people, and where there are a number of state laws already, but they're very different about how much help they actually provide to low-income patients. So we kind of made a recommendation that was more generous than what some states are doing right now. And then there's another set of proposals that involve debt collection, so that put limits on the kind of aggressive debt collection practices I talked about earlier, wage garnishment, and that sort of thing, suing patients, that would cap interest on medical debt, which I know Washington State had done something similar to that in legislation recently. So, and would strengthen notice requirements for patients. So there are a number of different recommendations that mostly apply, I think, at the state government level, but some of them also can, could be useful to look at for federal legislative purposes as well.
By the way, for some people who might just be joining us, I want to welcome you to this panel discussion brought to you by Consumer Action. Our panelists are Jane Sheehan, Director of Federal Relations at Families USA. They're a national leader on healthcare issues representing healthcare consumers. Jenifer, who was just talking, is an attorney with the National Consumer Law Center, a national nonprofit specializing in legal issues on behalf of low-income consumers. And we have former Congresswoman Allyson Schwartz, President and CEO of the Better Medicare Alliance, the leading research and advocacy organization supporting Medicare Advantage plans. I want to ask you a question, Congresswoman, and that is you're doing a lot of proactive stuff through these Medicare Advantage plans. There's something where you actually go out and call people. Can you tell us about that?
Well, this is in the innovations. That's one of the also, I think one of the real advantages in Medicare Advantage is that because they have more flexibility than traditional fee-for-service, and also, again, get a lump sum per member per month, there really is the opportunity to really innovate in some care delivery models. And, you talked about COVID. It's hard to go through a conversation right now without talking about COVID. And so we were particularly proud of really our ally organizations. I spent a good bit of time not like talking to the CMS and to Congress about what they ought to do, and hopefully they would do it during COVID, but also in reaching out to our ally organizations, a lot of the provider groups, the plans, some of our community partners. And what we found is that as the entire healthcare system got turned on its head in a way that was more disruptive than I think we've ever seen in our lives in healthcare. And not only did medical offices close down, hospitals ended elective surgeries and elective admissions, and cleared the way for those who would be infected with COVID. And they needed to do so. But at the same time, they needed then to transition to how do you then still take care of everyone else? And the healthcare needs didn't go away for everyone else. I talked about chronic conditions. It didn't mean that you didn't need your prescription renewed. It didn't mean that you didn't need to see your clinician. And so one of the things we found is that telehealth, people have heard a lot about this, I hope, but is that they really transitioned. A lot of clinicians transitioned to doing office visits, basically, by video like this, on a more secure site, and even doing some visits at home. So we had a couple of our provider groups, first of all, that really could switch more readily because they were already using telehealth. We just did a report on this. You can go to our website at Better Medicare Alliance and look for that report. That really talked about the fact that Medicare Advantage plans, because they already were working with some telehealth groups or doing some telehealth themselves, already had some mechanisms to do it and could kick it in pretty quickly. And because they had care managers, they already had people who they could say, get on the phone, call people, because they also have a panel of patients that they're taking care of and do some known as risk stratification. Some of them had lists of their patients who are at higher risk. They had people on the phone calling people and making sure they got what they needed. And sometimes they found that some of that had a lot to do with social needs and economic needs than it did even with clinical needs. And of course, those two symptoms go together, as we know. And so some were already doing meal delivery post-acute. They switched over to, can we get you a meal delivery now? If you're frail, elderly, living alone, have no help. So they did meal delivery. Another group actually did something that they called happiness calls, but they basically found that also that when seniors, in particular frail elderly, were so alone and told that they needed to stay home, they missed going to maybe that senior center, or they missed going to see their family. And they needed contact. So they created weekly calls or more to make sure that they stayed in touch. And all of that actually, I think, is helping to inform what do we do going forward? What works best? What could we still do through telehealth? What else should we be doing around social risk factors? I'd already started under this other efforts on flexibility, but I think I heard one clinician say, they thought they were doing a really good job of really understanding people's lives and how it affected their health. But COVID made it amplified it even more to understand the degree to which they have to pay attention to these other socioeconomic risk factors that make such a difference in people's health and ability to access healthcare and the ability to actually be well. So particularly as they age. So I think it was a it's still a tough time, and it will continue to be a tough time. So we'll need to continue to see how we can use these innovations, and not just in Medicare Advantage, but maybe across the healthcare system.
And once again, we'll be talking all about telehealth tomorrow, so please tune in and join us. Janie, I want to ask you a question. We were talking about going through the medical bills to make sure that, that everything's there you should be paying for, et cetera. I mean, that'll blow your mind if you try to go through these bills. What about the possibility of using some kind of advocate or paying somebody to do that? Do you get into that at all? Do you recommend people who have huge medical bills maybe pay somebody to go through it for them? Because I know they've turned up lots of money that shouldn't have been paid in cases I've heard about.
Yeah, I'm not kind of the expert on that end of it, but I would say that just consumers we've talked to in terms of our storytelling around surprise medical bills, I know some of them have gone to organizations either like NCLC or, like in the video you showed at the beginning, Consumer Reports. And these are, advocacy organizations that their goal is to help these consumers. I know of other folks who have, they've written their attorney general in their state. They've written the State Department of Insurance. They've had like endless phone calls with the consumer assistance folks at the hospital. And I think just, the bottom line there is just that when you or your family receive a bill like this, your first thought, you're overwhelmed by this large bill, but like the time and energy there that a lot of consumers have to go through, that's really better spent just on your recovery and your family's recovery. So it's really unfortunate that so many families, in order to fight these bills at all, have to go through all this effort. I think, there are avenues to receive help when you get a bill like this, but at the end of the day, the protection for people going forward is really the most important thing for us.
Jenifer, one of our audience members had a question for you. The question was, wasn't there a hospital that actually sued its employees on medical billing? Are you familiar with something about that?
Yeah, there have been a number of media accounts of, some of these really sad medical debt stories and just really aggressive collection actions against people who are low income. And one series that I think was really illuminating was ProPublica, and the MLK 50 had covered the Memphis hospital, Methodist Bonheur Hospital. And the hospital was, they may have had a financial assistance policy, but they were pursuing people for very low medical bills and pursuing them pretty aggressively, like garnishing wages for people who were minimum wage workers who had no hope of paying it back. And some of those people were in fact the hospital's own low wage employees, which was particularly sad. There was also a debt collector that so when I should just step back and say, like, so there's the hospital itself might have an in-house debt collection office or arm or something, or they may contract with an outside debt collector. I think in the case of that Memphis hospital, they actually owned the debt collecting affiliate. But so then the debt collector, often they make their money by adding on certain fees and charging interest, and the medical debt might start out as $2,000 or $5,000 and could double. It could keep going up from there when everything else is added on. So that story had actually like a pretty good outcome, because the hospital really responded to the negative publicity and the pressure, and they took a number of steps to put some limits on what they were going to allow debt collectors to do and to stop garnishing wages. And also they took, I have to give them credit for this, they took another step of looking at the wages of their own employees and saying, we really need to raise the wages of some of these workers. So that has been, there have been stories about hospitals in Virginia. University of Virginia Hospital, had a bad track record in that regard. There was one recently in Kansas, Olanthi Medical Group, I think, that was suing a lot of people. There, from time to time, these stories come out, and that often brings about changes for those patients, which is great for those patients, but obviously not a systemic fix.
We were talking about prescription drug prices, and I want to share a story with our audience and you three, and maybe somebody wants to comment on this. I'm working on a story for Checkbook right now about how it's sometimes cheaper to buy your prescription drugs if you don't use your insurance. So I have a situation where I was getting a drug that had a $20 copay more or less through my Medicare Advantage plan. And all of a sudden it was a generic, it's been a generic for a bazillion years. And all of a sudden they changed the formulary, and I go to the drugstore to pick it up and they want $122. And I literally almost had a heart attack. And I said, no, that's not going to work. Thank you very much. And I drove home and got on my computer and I went to GoodRx. People may have seen those commercials, save up to 80–85% on your prescription drugs. It sounds like it's too good to be true, but it really isn't. And I found a coupon that if I drove 1 mile from my house to that store, as opposed to 1 mile to this store, that same drug was going to cost me $12. So $12 without insurance, or $122 with insurance. My wife has 2 drugs, the same situation, generic, bazillion years, but more or less a $20 copay. All of a sudden it was $141 per prescription. Found a coupon again on GoodRx. It was $11 or $12 for each one of those drugs by driving 1 mile in that direction versus driving 1 mile in this direction. Doesn't make a lot of sense. It's like, I mean, that's when people look at this healthcare system. It's cheaper not to use my healthcare insurance that I pay money for to get my prescription drugs. Any of you three have any thoughts on that and why this makes any sense at all?
I have another example that I could quickly add. And this is, it's an unfortunate example, though. It's when I worked in legal aid before I came to National Consumer Law Center. I worked with a lot of people who were having trouble accessing mental health and substance abuse treatment with their insurance. And I actually had a person who had insurance through his workplace, and he had a substance abuse problem and was in methadone treatment. It was cheaper for him to pay out of pocket for the methadone treatment than to pay the copay that his insurance plan charged. And I just thought that was, you know, that's a terrible barrier to getting treatment for something so important.
Congresswoman, it doesn't make a lot of sense. I pay my money for my Medicare Advantage and it's cheaper not to use it. What's going on?
Yeah, I can say, first of all, I'll say a couple of things about this. And this is, again, a situation where there are really there's several proposals in Congress around drug prices. It's what we hear from seniors. And of course, it is, I think, the biggest concern when people say they're really concerned about the cost of healthcare. They're concerned about their medication costs. And often you hear more complaints about the high-priced brand name drugs where there's no competition, and those can really be out of sight in terms of the costs. Then, you know, under Medicare is Part D. It's been around for 20 years. It was controversial when it started, but it actually is working. It's the only way we actually negotiate drug prices. Government doesn't do it, but the plans do it. The Part D plans do it, where they negotiate drug prices with the pharmaceutical prices. I mean, our own feelings, first of all, Medicare Advantage, one of the good things is if you can negotiate for a whole lot of people, you have a big plan, you have a formula you negotiate with, you can get prices down. We have seen the premiums go down in Medicare Advantage for the last few years for drug prices. Most people now buy Medicare Advantage Part D plan with a very low premium, which is really great. There also is an out-of-pocket cap, annual cap in Medicare Advantage, which doesn't exist in Part D. We actually support an annual cap for consumers so that at least you know that you're taking either a lot of drugs or one of these very expensive drugs that you don't have to pay more than a certain amount of money every year. That would be very reassuring to consumers as well. So, but there really is, you have to get to the root of the problem, and the root of the problem has to do with manufacturing costs. And there's really very little line of sight into what those costs are, and really no regulation on those costs other than this negotiation. So that's a problem. And we think that there ought to be some solutions, and we believe that the consumer has to be protected in this. I'm not saying pay nothing, because consumers will probably have to pay something, but certainly for those either taking a lot of medications or taking these very high-priced drugs, it's almost unaffordable. And if healthcare is unaffordable, it's not accessible. So we're encouraged by those.
GoodRx able to get me that drug? Let me ask you a question. Why is GoodRx able to get me that drug for $11 when I pay money to my Medicare or my Medicare Advantage and it's $122? How can they pull it off when the insurance company or Medicare can't pull it off? That doesn't make any sense.
I don't have a question for that. They obviously either have maybe one of the other panelists could speak to that, but I'm assuming they're negotiating prices with drug prices or where they're buying their drugs. I don't know. I really just don't know much about that. Those who are, being able to sell it sort of offline, there is sometimes there are, certainly there's some pharmaceutical companies that give consumers a price break at the counter. So that I do know about. So if you go and say, I'm not covered, or I don't want to use my insurance, or sometimes, or the pharmacist might even suggest that you can say, well, there are some programs where you can get a less expensive drug. I know about those. They exist. They are intended to help people who are particularly vulnerable at the counter to not being able to buy their drug. Some of these other companies, honestly, I can't really speak to exactly how they manage to make it so inexpensive. I assume when, I guess, was it Walmart was doing $4 prescriptions no matter what, that was pretty appealing also. So look, you hope some of this competition also has some impact on the ability to bring down drug costs for everyone. Maybe that's a positive that there are some of these other companies starting to do it. But I can tell you that as far as Medicare Advantage, there's every effort being made to bring down the cost for consumers and to keep consumers finding their drugs accessible, and actually to encourage them to take them, to fill their prescriptions and to take them. Much more harm happens when you really need to take a medication and you don't. So I think for many of us, we're on the same page here. The question is, how do we get there?
Well, for everyone watching, I would highly suggest that when you go to the pharmacy, ask your pharmacist, and this is what Consumer Reports recommends, what is the cheapest I can get this drug for? And your pharmacist will maybe offer a way to get it cheaper. And if you're not sure about the drug, just go to GoodRx, go on your phone, GoodRx or one of the other coupon programs, and see if you can get it cheaper. It might actually, as crazy as it sounds, it might be cheaper to buy your drugs not using your insurance program than it is using your insurance program. My example, $122 versus $12. Just keep that in mind. Jane,
can I quickly say, I just want to note that there are 4 of us here who are pretty savvy about these things, and none of us can explain why it's happening. And I think that says something about the situation that you described.
May have something to do with coupons, because I know under Medicare Advantage you're not allowed to give a coupon. I don't know whether they're outside those rules, and
Medicare Advantage, Medicare. The coupons work if you're on Medicare or Medicare Advantage, so it does work. I checked that out for my story. It'll be up on consumercheckbook.org in about a week or so. One of our viewers had a question for you. Could you possibly give specific states where there is protection against balance billing, and also are there any loopholes people should know about?
Sure, absolutely. So I think as I mentioned earlier, a good number of states have moved forward with their own balance billing protections. If you want like a really awesome state-by-state view with all the details, I recommend going to the Commonwealth Fund's website. They have both a map of state-by-state and then just a really great chart if you want to kind of go down into the weeds. But kind of two examples of states that have had surprise billing protections enacted for a few years now, California and New York. Both of these states are often kind of used as examples during the fight at the federal level because they go about the payment mechanism in slightly different ways. So both of the states protect consumers in emergency and non-emergency situations for basically, everything, all insurance except, those self-funded ERISA plans. California solves the payment mechanism by going with basically a benchmark rate. So it's, I think California, it's the mean or the average of what other providers are paid for that same service in that area. And then in New York, they have what's called an independent dispute resolution process. So that's when the provider and the insurer go to this kind of arbitration independent process. And there's an arbiter who can, look at a few different things to kind of make the decision. And then, they kind of choose either what the insurer is putting forward or the provider is putting forward. So both laws have been in effect for a while. I think overall consumers have been protected in these states. And I think there's differing analysis on, if there's been an impact on healthcare costs writ large, because one of the big concerns at the federal level that Families USA is working on is that if the solution does rely too much on the independent dispute resolution process, or if something like billed charges, which is what the doctors and facilities charge, which doesn't always have a lot to do with what the actual cost of care is. It's often many times what Medicare pays or what the insurers pay in network. If the process relies too much on those things, then healthcare costs could really skyrocket kind of on the back end, and consumers would be hit with higher premiums in years to come. So those are two routes that states have taken. I know that very few states have been able to tackle the ground ambulance portion of it, and that's also something that the federal policymakers have had trouble looking into. That's because, ground ambulance is often, it's owned by municipalities or localities, and it's just a lot harder to regulate, especially on the federal level. I know Colorado has moved forward with some of those protections, and a couple other states. And then, of course, air ambulance is something that can't be done on the state level. So that's a big loophole. And then, of course, the ERISA plans.
Isn't it when you call 911, you may not even be sure which kind of ambulance is going to show up? I mean, in some cases in ours, we have Medic 1, you might get that, but if they're already out at other calls, you might get a private ambulance coming, so you don't even know who's going to show up.
Absolutely. Totally depends on where you live. And, if it's a rural area, an urban area, what your municipality or city has been able to kind of work out. And it's really this patchwork system. So you definitely don't, the consumer definitely doesn't have a say in who's picking them up. And
right.
It's the last thing they're worried about.
Jenifer, can you negotiate with the hospital and say, hey, I got this horrendous bill, and it's just, I mean, there's no way, can we talk about this? Can we negotiate this deal, something like that? We talk about always negotiating with creditors. Is that something people can do?
Oh, absolutely, yes. And that's when I represented clients, I often would be negotiating their medical bills with hospitals. So with hospitals, sometimes even with the debt collector to work out a payment plan. But I think negotiating with the provider, I would, I guess, first recommend trying to chase down every way that the bill might get paid through, through financial assistance or, some insurance coverage or, other programs that you might have access to. But yes, you absolutely can work out a payment plan. And I think a lot of patients sometimes will have success in negotiating something that's lower than the charge master rate. I think we talked about the charge master rate a little bit earlier. That's sort of the sticker price for the healthcare that hospitals are required to post online, but then they have a much lower negotiated rate with insurance companies and an even lower rate that they would pay Medicare. So someone who's financially struggling might be able to get the hospital to agree to accept the Medicare rate, over a period of time.
And if you are freaking out because of a medical bill, maybe you should contact a nonprofit credit counselor and have them work with you and figure out what they can do to help you pay these things. They deal with people all the time and who are just totally stressed to the max and trying to help them figure out how they're going to pay their bills.
I think just, finding, a reputable credit counselor, I think that, that it's something that could be helpful in certain situations, but really patients can negotiate these things themselves as well. The problem with that might be, as Jane pointed out, you've just had, a procedure maybe, or, you've just given birth as in the video at the beginning, and it's not like the first thing that you're ready to do is to start like fighting over a healthcare bill.
Jane, somebody asked, what was the name of the website you just gave? The
Commonwealth Fund.
Commonwealth, COMMONWEALTH Fund, Commonwealth Fund. Okay. Congresswoman, there's a question from you. Somebody wanted to know if the Supreme Court throws out Obamacare, will that have any impact whatsoever on Medicare Advantage programs?
Oh, that is a good question. I think it's yes, it would. Under the ACA, it did a number of things for Medicare Advantage. It actually established a quality measurement program under Medicare Advantage. It's called the star rating system, so that every plan has to meet certain quality measurements, and they get a performance rating on a 1 to 5 star rating. And it's been a remarkable success. I think in the beginning there were about 26% of beneficiaries were in high quality plans, 4 and 5 star plans. Now it's over 80% are in high quality plans. So the plans work really hard to meet those quality measurements, and the providers do too. And the government keeps moving those measurements to get tougher, so you can't just stay in one place to get them. And that's in the ACA. So if the whole ACA goes away, we have to reconfigure that. I think people think it's been an enormous success, and we should keep it. Those are the many things. It's one of many things in the ACA. Should it go away completely, that people don't talk about or hear about? I mean, I was involved in the ACA my bill on pre-existing conditions. I mean, it was just the incentives for primary care, I mean, are just all gone. It's just, not to mention some of this, the real efforts to the innovation center at CMS, where you can do model testing of demonstrations to see what really works and whether it works better, and to monitor that. Not to mention the millions of people, the 20 million people who would lose their coverage. And that doesn't even include the people who could have coverage now or in states that didn't expand their Medicaid. So I'm sure the others want to talk about this too. This is just, it's such a deep concern for any of us who really work on healthcare to think about, losing the whole ACA, and that effort by the administration is really tough. And even the president himself said recently, well, we really like a lot of it, and we did some things that maybe made it better. We can disagree or agree with that, but it's now a part of the way people who are uninsured get health care, and the individual market was a very problematic market. It was expensive and not accessible. And the other panelists can talk about this more than as well as I can. And to lose those subsidies, to lose the ability to have access to affordable care, to make some choices there, to have more people eligible for Medicaid, to set standards for employment coverage. I mean, you name it. I mean, I could go on and on. Felt like 2 years of my life doing this. It's really, to go backwards on this is really very troubling. And we just have to hope that it doesn't happen. And if it does, that we have the ability in the House and the Senate and the presidency to actually find a way towards universal access to healthcare coverage in this country. It is, I believe, healthcare is a human right. I think there's a lot of different ways to get there. And I think there's an American way to figure it out and to get there. And I think we were on our way. And not that we couldn't all sit here coming up with reasons we couldn't make it better, but just as our nation, we're not perfect. We have a lot of work to do to be a more perfect union. Healthcare is the same way, but I hope that we don't have to completely rebuild, and if we do, that we actually have the political will to make the kind of progress that we've seen in the last few years, where we could keep the uninsured under 10% and continue to make it more affordable, better coverage, better healthcare, and better outcomes for all Americans.
For a timeline perspective, for people who are worried about the situation, if I have this right, the Supreme Court's going to hear the case sometime right after the election, and then they probably won't have the ruling until sometime in early 2021. So I would assume that everybody who's signing up the plans would probably stay in effect through 2021 and be dealt with after that if the court were to strike it down. Is that a fair scenario? Do I have that right?
The others maybe I'll say this. I think it will take time to unwind this. I don't think that it would be attainable to actually say you have no health coverage next month, so how that exactly gets done, there'll have to be a bit of unwinding for sure. But look, I hope they believe it's severable. And what can I say? I'm not a lawyer. I'm certainly not a Supreme Court justice. I hope that they take this as seriously and understand it. Like, they have to go by the law, but because we passed a law that's been in effect for a long time, and a lot of dispute about this, but they're even just starting back to the simplest fact of not having pre-existing condition protection in this country is a deep worry. It's really hard not to have something, particularly when you get to a certain age, that couldn't prevent you from either getting insurance at all or getting insurance you can afford. And we have found a way to deal with that, and we should. And again, this is finding, apparently there's common ground on this. So why this is at the Supreme Court is one that sort of still, even for me, and I'm a sort of experienced policymaker here, that it got to this place is really, really distressing.
Jane, I know you want to say something. Before you do, I was at a conference, Consumer Federation of America conference, a couple of years ago, and they always start with the Pew Charitable Trust doing the survey they do. It's nonpartisan in the state of America, and they ask people about Obamacare. And it was very interesting. When you ask people what they thought about Obamacare, it's sort of ranked here on the scale. But then when you ask some of the individual things, is it important to have pre-existing conditions covered? Is it important to have your kid on the insurance policy? Well, 26, 96%, all the things that were covered in Obamacare, everybody loved. They just, when you said Obamacare, because of the political nature around it, the whole thing rated lower, which a lot of it's a communications problem or a misunderstanding problem, or the way it's been so politicized. It's very interesting that people don't get a lot of this stuff that could be taken away if the court rules against the law. But Jane, you had something you wanted to say?
I think I would just adding to what the Congresswoman was talking about, this is kind of like, she summed up really well all that's at stake here, but it is this existential really threat to the healthcare system. Opponents of the ACA tried for years and years and years and years to chip away at it legislatively, repeal it whole cloth. Back in 2017, we had this really intense fight as consumer healthcare advocates to, maintain the Medicaid program, maintain the ACA, and we won because I think, as you said, when you say like Obamacare or the ACA, even people don't always understand what that means and what it protects, the protections that they get from it and their neighbors and their family members. But when you go through the pieces, Medicaid and what Medicaid means to people with complex healthcare needs and long-term care needs, what pre-existing conditions protection means, what all of the financial assistance in the marketplaces. Once people have this and understand what it means, they don't want to see it be taken away. So I think, we'll see these oral arguments in the Supreme Court, I think the week right after the election. I would expect, given how the Supreme Court usually works, a decision maybe not until the spring or early summer. And from then, I think depending how the court weighs down on it, it could turn out a couple different ways. But we're going to have a new Congress and potentially a new president. So I would just hope that maybe there's also ways to address coverage that way if we do have the worst case scenario. But it could be a pretty dire situation.
And correct me if I'm wrong, but if people don't have health care coverage and can't pay the medical, somebody's going to pay. It's not like this cost goes away. It's going to roll onto the hospitals or the local governments or the right, Congresswoman? It's not like you don't have insurance. Oh, okay, I'm going to go to emergency and get taken care of. And nice to know you. Somebody's going to pay that bill.
We all need health care. You're right. Yes, people still have their employer coverage. They will just, Medicaid will still exist. Medicare will still exist. Even Medicare Advantage will still exist. But I think this is the moment when those of us who care about healthcare, and honestly, all of us also, even if we're not professionals at this, everyone cares about healthcare. It's if it didn't affect you this year or next year or last year, it's gonna hit you at some point, and you certainly have family members who you worry about deeply about this. And we've been struggling with this for a very long time in this country about how we can actually get healthcare coverage that's accessible and real coverage, and to make it affordable. And we need to move forward on that. If you care about this, I would say vote. This is not a panel to do politics, and even in my work, I work for a nonpartisan organization. I think we all do. So we're careful in some of wear our politics on our sleeve. But I was a Democratic member of Congress. You know where I am on this. But we need to figure this out. We need to not have we can have the debates about how we get there. But having the debate about whether it's a worthy mission or not, I think we're well past. And I think that's what is so troubling about this, is that they'll keep us all busy. We'll always be looking at how we could do it better. What didn't we get exactly right? But that is very different than saying we're going to completely undo such a major step in moving us forward, in helping to achieve a structure. At least that again, will I'm sure take tweaking, will take some changes over time, as it should. Medicare changed over time. It started out as hospital coverage, and then they added physician coverage, and then they added coverage for other kind of providers, and then they added prescription drug coverage, even if it's not perfect. These don't always address every issue we can imagine. We still have work to do to bring down drug prices and to regulate the pharmaceutical industry. Maybe that's why we didn't know the answer, because it's not regulated. We don't have any information about where these prices come from and what they do with it. That's not right in healthcare. It is a different kind of commodity. You don't always choose when you break a leg or get cancer. You should be prepared. I actually believe that people should have coverage. But it is one that we as a country just have to keep moving forward on rather than moving backwards. That's certainly my hope.
We're getting close to sign-off time, so I want to go round robin here and ask each of you, and we're no rush, but each of you to share something that you want the folks watching today to know about the healthcare system, about something you're knowledgeable of, maybe some tricks or tips. Just leave us with some practical information if we could. And Jenifer, since you're at the top of my screen, I'm going to go clockwise. How about we start with you?
Can I do 2 if they're short?
You can do as many as you want. We're not in a rush.
Okay, well, in terms of consumer rights, I think that people should know under the Federal Fair Debt Collection Practices Act, if you literally have a debt collector contacting you about medical debt or calling you all the time, you do have rights. You can send a no contact letter. You can ask to only be called, during certain hours or not at a work phone number or that sort of thing. There are questions about what's going to happen to those rules, but there are those basic protections for consumers. So if someone is being harassed by a debt collector, then there are steps that they can take. I also realized I kind of neglected to mention too, we talked a lot about statistics about medical debt and, the percentage of people who have medical debt on their credit reports. And I just want to point out, something I'm sure we all know, but there's also like a large racial justice component to this too, and that the problem of medical debt is even more pronounced, unfortunately, for people of color in this country, and that there's a higher rate. I think 21% of Americans who live in zip codes that are primarily non-white populations have at least one item of medical debt in collections. And the research that I've seen certainly shows it is a more pronounced problem for a lot of communities of color.
And you wrote a book that people can get, and it's free. Tell us about that. I mean,
Thank you. Yes, I have a copy here, which I don't know if you can see well. Surviving Debt. Oh, is it backwards? Well,
no, you got it right.
Oh, okay. So this is our book, Surviving Debt. It's written for consumers. It's written for people to use to, it's not just about medical debt. It's also, student loan debt and, mortgage issues, and just all sorts of debt are covered. And it's full of practical tips for dealing with debt. The paper copy can be purchased online, but the online version, like the electronic version of the book, is free right now. We made it free during the COVID-19 crisis. So you can go to nclc.org and to our digital library, and you can get access to the entire Surviving Debt book that way. And I recommend it for anyone who, if you're a consumer or if you're working with consumers, it's got a lot of information in there.
It's a good book. I've used it for stories. nclc.org, the National Consumer Law Center. One thing to point out with the debt collectors is you have to be aware of bogus debt collectors calling. There could be somebody calling you, telling you you owe a debt, and you really don't owe a debt. You need to make sure you owe the debt before you talk to that person or agree to pay anything. Tell them you want to show me in writing. Send me the letter. Send me the validation letter, and make sure you really know you're dealing with somebody who's legitimate. I think that's right now with all this stuff floating around. I think there's going to be a lot of con artists who are trying to claim they're debt collectors and they really aren't. So, okay, Jane, it's all yours.
All right, awesome. So I would just say, just going back to what we were talking about before with surprise medical bills, this is an issue that Congress has the power to solve, and they are so close to solving it, and solving it potentially before the end of this year. So I would just encourage folks to talk to your policymakers about this and how it's important to you and your family. There's a lot of finger pointing in DC now and probably always, and I think the surprise billing debate has been framed as this this fight between the insurers and the providers, and we just have to remember that the people hurt by this are consumers and their families. And the system is clearly just stacked against consumers and patients in this case. We did some polling last year, and 9 out of 10 voters across party lines support legislation to end surprise medical bills. And by more than 9 to 1, these voters supported a solution that would protect patients while holding healthcare costs down and not increasing insurance premiums on the back end. This is an issue that is so bipartisan, and especially in healthcare, when you're working on healthcare policy at the federal level and the state level, it can be pretty rare to find an issue that is truly, it's not across party lines. Members of both sides of the aisle really want to find a solution here, because it's just this, a common sense solution to really just a big example of how the healthcare system can be broken for consumers. So, there's some energy right now to include these protections into, potentially the next COVID relief legislation, which has been a little slow to start, but we hope to see something by the end of the year. Probably won't move before the election, but we're pushing really hard to include it in the lame duck. And every day that goes by, more and more families are at risk, especially now during the pandemic when so many things are uncertain. So I would, just ask people if they care about this issue. Now's the time to speak up. If you've experienced a surprise medical bill, tell your story. Stories are so powerful, especially when, you know, when policymakers are just looking at data and these intense policies all day. By hearing from a real person, a real family, they're, you know, that really motivates them to act. So that's what I would say.
Jane, is there anything the folks watching, is there anything at all that we could possibly do proactively to protect ourselves? I mean, is there any tip, anything you can share? That some things are totally out of your control, but I'm thinking of, like, if you know that your plan doesn't cover one hospital but another hospital for whatever reason, and you're taken to a hospital and it's not a life-threatening broken limb, you know, should you tell the ambulance, I want to go to this hospital, not that hospital? Or is there anything that we can do proactively?
Yeah, I mean, I think, you know, unfortunately, a lot of people that get hit by these bills do so much research, right? Like, they talk to their doctor, they talk to the facility, and it is many times out of your control. But I mean, the Congresswoman's example of when she was getting surgery, and I just asked the, you know, the anesthesiologist, whoever's in the room, if they were the insurance network, if you have the ability to ask those questions, I definitely recommend you do ask those questions. Unfortunately, that's you can't always do that. And then I think when you get these bills, I think, you know, Jenifer and the Congressman gave just good examples of tips to do, but, you know, make sure things are accurate to the best of your knowledge. Ask for an itemized bill. Talk to your insurer. Talk to the provider. Just see if you can figure it out, and see if it actually is a balanced bill. But yeah, I mean, as much research as you can, and unfortunately, that's kind of the state we're in now. But hopefully, someday soon, this particular kind of egregious bill won't be hitting that many consumers.
As I say when I make speeches all the time, sometimes we need regulations to fix a problem, to make it a level playing ground for people. I think this is one of those situations, it sounds like. Congresswoman, go ahead.
All right. Well, I'll try and be quick about this too. Hard to make a small list, but I'd say first, Medicare it's 55 years old, and it is an amazing program that got started with an early vision that we needed to provide that kind of financial security and healthcare security for seniors and not people with disabilities. So let's protect our Medicare and the promise of Medicare, which also doesn't mean that it can't be modernized, that there aren't ways that we can, that we're already doing it, and Medicare Advantage is doing that, really modernizing a program that's worked so well but could actually even be even better. And as we face real challenges in the healthcare system, and that's including financial ones going forward, to make sure that we actually protect the innovative modernizing of Medicare as well. And I would say, so I'd say two specific things, is to know that there's some good things happening out there at this moment of COVID. And sometimes we do look at, this is really such a difficult time, but there is a lot of innovation happening that providers and plans and community partners, we have Meals on Wheels and, so many other partners that are doing things for beneficiaries right now that is really making the healthcare system better, and we hope to hang on to that. So I guess I would just close by saying, on behalf of consumer action, that be the best consumers you can. This is complicated work. We're trying to make it, we fight for it to be easier and more understandable. Health literacy is not high in this country, even those of us who think we know healthcare. Remember when the ACA came in and all the members of Congress and our staffs had to go into those exchanges? We made that the law. Everyone's like, okay, what do I choose? What do I choose? What do I do? They said, wait a minute, I'm supposed to know this. So the fact is, you don't have to be an expert, but you have the right to demand the information, be able to get the information. We want to make it understandable. We want to make it simpler, and we want people to be able to make the best choices for themselves and get the care that they need. So just know that work's going on, that working in alliance as we do, with Consumer Action being one of our allies, friendly with some people at Families USA as well, and some of the work that you're doing. And I don't know you as well at the National Consumer, but certainly it's, we do try to work together where we can to make sure that we can ensure that consumers are protected. They have responsibility themselves to be good healthcare consumers, but to make this work for all of us in a way that is affordable and accessible and quality healthcare. Let's not lose that notion of quality care at the end of the day. If it's not quality coverage or not quality care, we really have missed the boat in fighting for just coverage. So it's all about all of those things. And I think America, I'll do my congressional thing. Like, America is a great country. We could do this, and we'll get it as right as we possibly can going forward. But thank you to Consumer Action for the good work you've done with us, and for being advocates for seniors and beneficiaries in Medicare, including Medicare Advantage.
And we cannot repeat enough that with open enrollment season coming around, don't assume that the benefits you had this year are going to be the same for next year. You've got to go through that whole process over again and check that it's the right doctors, the hospitals, the right drugs. Make sure you have the right plan for you. Things could change. Yeah, that's just the way it is. You've got to do that, because if not, you keep going down the line and you could be in the same policy that's not really right for you anymore. So that's really, and there is help. I know you can contact your state insurance commissioner's office, and like ours has a SHIVA program, the senior volunteer that will work with people. I think AARP can give some help. Anybody have any other places where people might be able to get?
A lot of people use agents and brokers as well, and I would, and you don't have to pay for them either. So you're right. The SHIP counselors are called something different than Pennsylvania. They're called a prize. So it's, but ask around. I would say that you don't have to feel like you can struggle through this alone. We know people go online and they look at it, and it's like 15 minutes later, like, oh, I'm done here. This is too complicated. So by all means, ask for help if you need it, and use a volunteer counselor, use an agent broker, call Medicare if you need to, and make sure that you are making the best choice for you. And you're right, it isn't the end of the time. You actually do have time to make that change every year. So that at least is a little fail-safe there. But it's a challenge. But if you love what you have, you can keep it. But it is, I think, Herb, you're right. As a good consumer advocate that you are, it's worth checking out the other options and see if that's right for you as well. And seniors who live on a fixed income, saving a few dollars, getting extra benefits, it matters a lot.
I mean, especially if you lose a pharmacy or a drug or a hospital or a doctor that's really real. I mean, I have a doctor I had for 20 something years, and that doctor's got to be on the program. And if some of them dropped them, for whatever my provider in Seattle, some of the policies dropped them. And that was like absolutely critical for me to make sure that I had my hospital and my doctor on the program, because this person had known me for years and years and years. And you can't just assume that they're on there, because these things really do change.
Absolutely. More and more people are signing up for what are known as HMOs or managed care. And what that really means is a network of doctors. And that downside is you can go outside the network, but it can cost you more. It's likely to cost you more, but you need to know that. Or you just picked the right network. Or if you travel a lot, if you're really, really picky, if money doesn't matter, you maybe have other options. But it's worth checking out whether this is actually a network. There's some people who also find networks really helpful, because healthcare is also very fragmented. And it's sometimes hard to navigate the healthcare system without a network of providers who are working together. So it's not always it shouldn't be seen as a negative, because it actually is often very much a positive for people who say, I know that my care is getting coordinated across the network. They all can see the same medical record. They all know who I am. They help push me. They check out my medications. I have a primary care doctor. Boy, that really makes a difference in people's lives.
It does. Well, I want to thank our panel members. This was a great discussion. Jenifer Bosco from the National Consumer Law Center. We have Jane Sheehan from the Families USA, and Congresswoman Allyson Schwartz, Better Medicare Alliance. Great discussion. Thank you very, very much. For our audience, we're going to be back doing this again tomorrow at 10:30 Pacific, 1:30 Eastern. And we'll be talking about telemedicine, something that I've experienced a couple of times in my life because of COVID. You can't go to the doctor, so they call you, and it actually worked really, really well and saved a lot of schlepping down to the hospital. So, but there's some good things and bad things. And again, it's a system that's going to be used more probably in the future, and we need to talk about it. So we'll see you again tomorrow. Thank you all. And remember, get your flu shot. Have a good day. Bye.
Bye. Thanks, Herb.